Well, good afternoon, everyone. Thank you very much. Appreciate the opportunity to be here and visit New York. We're going to talk about one of the more complicated areas in the areas of treatment of malignant lymphomas. How can we have a disease called follicular lymphoma where we can have so many options that range from doing nothing for a patient to doing high-dose therapy with transplantation? It's a very complicated story. And what I want to remind you is the history of the past 20 years, 30 years, where overall survival was never impacted by alkylating agents, anthracyclines, or combination chemotherapy. And the standard wisdom was that overall survival for all patients was 7 to 10 years. And this was called good news in a relatively benign course. If I told this audience that half of you would be gone in 7 to 10 years, I suspect you would not be thrilled with the results I'm giving you. And in fact, less than 20% of the patients were alive at 20 years. Watch and wait was brought forward as not reducing the overall survival, but there was never any indication whatsoever that it lengthened the overall survival. So Dr. Rosenberg at Stanford was known to say overall survival was not a reasonable endpoint for clinical trials because it could never be changed. And this was the curve from Stanford over many years, median survival 7 to 10 years, and no real plateau. And so that's what we were looking at, and I will argue that the world has changed dramatically since then. And what changed the world? Rituximab, without any question. The concept that you couldn't change survival was true because we didn't have very effective therapies. And as soon as we added rituximab to chemotherapy, CVP, a straightforward British study in this case, we had enormous differences in time to treatment failure, and even overall survival began to look good. The Germans did it with CHOP, a complicated study, but just focus on the first randomization. R-CHOP versus CHOP, follicular lymphoma, same refrain. Time to treatment failure, major difference, and a statistically significant survival advantage with enough patients in their studies. So if you have enough effective therapy, you can change the survival. Why couldn't you when the median survival was only 7 to 10 years? It's not that hard. It's not pediatric cancer or early stage Hodgkin's disease. And in fact, the meta-analysis of all of the trials that included rituximab with chemotherapy show an advantage. It's uniform, either borderline or strong in that case. So the question is, are clinical trials really not necessarily reflective always of the population? We understand that. So has overall survival really improved? And this is one of our papers from the SWOG group looking at our clinical trials over 3 to 4 decades. And what you see is that as the initial therapy changed and as monoclonal antibodies were added, overall survival clearly improved. Patients getting treated more recently and with monoclonal antibody have a much different overall survival. No longer is the median at 7 to 10 years. In fact, 70% or 80% are alive at 7 to 10 years. This came from the MD Anderson, where their sequential studies, again, got better and better, and then when Rituxan was added, the more recent studies had a benefit. This came from the German non-Hodgkin's low-grade lymphoma study group, where again, as they began to add in our chemotherapy, they got a major advantage. So the major thing I'm trying to tell you today is the prognosis of patients in this day and age is dramatically different with advanced stage follicular lymphoma than it was 20 to 30 years ago. That puts a certain burden on us. That puts the burden of not making changes that will reduce that survival. And it actually, if people with the median age of this disease is in mid-60s, and if the median survival is 7 to 10 years, can we begin to ask whether some of these patients are cured? That's a lot of people who will die of other things other than lymphoma, which is not a bad definition of the control not affecting lifespan with lymphoma. Okay. Along came the PRIMA study, a controversial study in some points, not so much in my eyes. Dr. Friedberg will argue otherwise. that AD patients were chosen by their institutions to get R-CVP or R-CHOP, and then they got maintenance rituximab. The only point I want to make here, as you know, maintenance improved PFS, did not improve overall survival yet. But what was interesting is if you looked at the institutions that chose R-CHOP over R-CVP, there is no question that the patients in the institutions treating with R-CHOP did better in both PFS and overall survival than the patients getting R-CVP. Again, in this case, suggesting that intensity of therapy did make a difference. Bendamustine came along, and this is an example of a new drug which clearly has activity and was touted as being significantly better than CHOP or R-CHOP. But in fact, this study has major, major problems. I won't spend a lot of time going into it. There are problems with endpoints here. This is the worst looking R-CHOP curve that's ever been generated. The toxicity on the R-CHOP arm is dramatically different than anyone has ever seen using R-CHOP. And in an elderly population, it was clear that growth factors were not given in an appropriate way. So there are a lot of problems. I do think it is probably reasonable to say that our bendamustine is probably not worse, but it's hard to prove that it's better based on this. Specifically when the confirmatory quote study came out and showed exactly the same response rates when R-CHOP and R-benda were given. But it does support another version that our chemotherapy is valuable and good depending on what you choose for them. And I'm not going to focus on that. So just look at what the STILL study had for R-CHOP of 52%. Look at the SWOG most recent study for R-CHOP at 70% without maintenance, and look at the PRIMA data with R-CHOP plus R maintenance. The only point I'm trying to make here is that there is reasonable data to suggest that if you give R chemo and R maintenance, 85% of the people will be alive at 3 and 4 years, and that is something we don't want to give up. So, before I go into this, let me just say, the question is, what are the alternatives to this? And in this case, I'm not sure what Dr. Friedberg's going to argue, because we haven't talked about it yet, so I'll learn as you do. But he could argue several ways. He could argue that watch and wait was still the most viable therapy for most patients. Most of the country has moved to rituximab initial therapy. And it may be true that in elderly patients with minimal tumor disease, that's a fine therapy. We don't have proof it's inferior in any way, shape, or form. But if you're looking at people who have 10 and 20 years survival, we don't have that kind of data yet on the R follow-up to suggest that. Dr. Chesson and our hosts here at CLGB, who succeeded Dr. Chesson, have argued that we shouldn't be giving chemotherapy anymore at all. We should be in the new biologics because they're pills, they're easy. But do they work? So you all know that BCR signaling is very important in lymphomas, and that there are many LIN, SIG, BTK, Blink, et cetera, all antagonists are available. And I just show you this from Nathan Fowler using ibrutinib, and it has a follicular lymphoma, second from the right. And what do you see? In relapsed refractory patients, it has a 40%, 30% response rate. Remember that no one has ever been cured by one of these BCR inhibitors. Remember that as soon as they're stopped, the wisdom is generally that the patients relapse. And so to think that we can, in fact, use these agents at this time in the upfront treatment of these patients and involve our chemo, I think is a big stretch. I have no problem with clinical trials in this regard, but the routine use of these agents, I think, has the potential of compromising what we've accomplished over the last 30 years. So what would I prefer to see? I would prefer to say we're not there yet, and I would prefer to say survival and failure-free survival are really important endpoints to my patients, and therefore I would like to move forward improving on what we got with R-CHOP, and in fact we are very anxious to take our chemo and add some of these new agents, the BCR inhibitors, to our chemo and see if we can move that from 70 to 80% at 4 or 5 years up to 90%. That would be a great improvement. I am less inclined to treat patients with rituximab or watch and wait, and I am less inclined certainly to just take ibrutinib and something else and put it together and offer it to those patients. I think 5 to 10 to 15 years from now, I hope we do not look back on this and say we jumped too easy for convenience and lack of toxicity, and now we have patients who are no longer surviving. So a very important discussion. These are my colleagues in the SWOG group who've been with me for almost 30 years now. And by the time I step down next year, it will be 30 years running the SWOG Lymphoma Committee. And I owe all of the work and most of the ideas that are here to my colleagues. So thank you very much for your attention.